Hey, good morning. Which button? Right one? Okay, cool. Hey, okay. I'm very happy to be here. I think it was maybe 20 years ago, I was at NIMH, and many of the program developers from prevention and a number of people from services research got together. Do you guys remember that? I think you were there. And we were talking about some of the same issues. So taking the long view, David, as you said, I think some of the issues around prevention and service systems we're still trying to get right. Knowledge base has grown. We've got a lot more to build upon. But what we're facing right now from a system standpoint are some of the most dynamic, unstable changes that we've ever seen. And so when we're trying to piece all of this together, I think we need to be aware of that and try to take advantage of it. I'm not sure that the push and pull metaphor is necessarily going to work for us. But what I'm going to be talking about today is from the state mental health standpoint. So I have a role in both New York State, in their Office of Mental Health, as well as at New York University, an academic researcher. And so what we've been doing is trying to pull together what the state policy demands are for evidence-based practice rollouts with opportunities for implementation studies that are funded by NIMH through our Advanced Center. So I want to talk about what's happening in state mental health agencies, state mental health authorities, and the agencies that they serve, and the changes that are happening, and where we're trying to target our implementation studies to have the biggest impact. Brian mentioned that in Pennsylvania, prevention does not have a system, and that's pretty much true in many of the states. Certainly the state mental health agency right now, prevention is a small piece, but it's not a huge piece. I think that's going to be changing as mental health and health line up more closely, which is happening. But a couple of things, let me talk about the federal, I hate it when this happens, you know? Jeez, that's annoying. Was there one more? Yeah, okay. All right, so a couple federal initiatives, you all know about these, the Mental Health Parity Addiction Equity Act and the Patient Protection Affordability Care Act, also known as Affordable Care Act. Those were big, and those have affected the states in terms of ways in which they're trying to redesign their system. Medicaid managed care is a huge force right now, certainly in New York State and across the country. And this is driving the way in which the plans and the state are thinking about rolling out evidence-based practices. It's not pulling back from that, but it's changing the way in which they're thinking about it and what kinds of outcomes are going to be important. The main concern is with costly services, high-end users, and access. But it does get to access for a population. So getting back to what Ron Prince was talking about, a population-based approach. I think we're seeing that mental health is lining up much more with a population-based approach as Medicaid managed care is coming in and as we're aligning more with health. So that's a good thing. Growing involvement of consumers, workforce shortages, health homes and care coordination, data monitoring and electronic health records, as well as quality measurement. These are big drivers now of the way in which states are thinking about how to redesign their system. And I think what we need to be doing as a group of people wanting to promote family-focused, effective, evidence-based practices is to be aware of these drivers and try to line up our programs, our processes, our measurement strategies, the way in which we talk about what we're doing with these kinds of drivers. Oh, shoot, there was one more, okay. Accountability and outcomes. Okay, fiscal crises. This is really bad news, but it's a reality. And the reality is that the states are suffering hugely. And this has been true since 2008, but and it may be shifting a little bit now as the economy is improving. But basically, 3/4 of the states have faced severe budget crises. And that has not gone away and probably won't go away in the near future. So how are states responding to that? Reducing community services, okay. reducing number of clients, reducing funds, cutting staff, hiring freezes, et cetera. So, this is a reality, and we have to be sensitive to it when we're working with states, that the budget crises are requiring curtailing of services and redirection of services. Now, the fact that, and I'll show you a slide in a minute, that evidence-based practices and those rollouts are continuing in the face of this, I think is another piece of good news. Another just piece to keep in mind, excuse me, 3/4 of the states are moving towards managed care for their behavioral health services. So what that means is that the function of the state mental health authority in overseeing those programs is not going to be as direct as it has been, because managed care organizations are going to be responsible for the populations they're serving. In New York State, we may end up with 5 different managed care entities. In some states there will be 1, it varies. But the truth of the matter is that the state's authority is going to be shifting to a certain extent, as what happens is that the plans, the managed care plans, are going to be responsible for many of the services. And then finally, workforce shortages. We've heard a little bit about that, but the workforce shortages are severe. On the other hand, the federal government is putting a lot of money into retooling the workforce, hiring other people to be able to do some of this work, and putting a lot of money into training. So I think this is another area where we can be thinking about the opportunities. So just a caveat here. These are data, they're preliminary data, so I hesitated to present them, but I decided it was important to, because the main point I want to make with respect to these data from NASHBIT in the National Research Institute is that there are trends in evidence-based practice rollouts. There are disparities between the extent to which states are investing with kids services versus adults. And states are responding in terms of evidence-based practice rollouts in some very specific ways. So the numbers may change. That's the caveat. Eric Bruns is leading these analyses with Ted Lutterman at NASHBIT. But the thing I want to point out here is that these are the evidence-based practices that the states are required to report in terms of whether or not they are supporting these kinds of rollouts. And the lines at the top are for adult supported employment, supported housing, and assertive community treatment. And then there's treatment foster care, multisystemic therapy, and functional family therapy. And the point is that the lines in the top that are serving percentage of states are for adults, and the lines at the bottom are for kids. So there's more of an investment in terms of the numbers of states that are trying to roll these out on the adult side, then the child side. But the other issue is that this goes from 2001 to 2012. And you see that the trend lines are sort of flattening out right now. So they're not dropping, which I think is very good news. States are not backing away from these EBPs, but we're not seeing a rise either. If we look at numbers of clients served, it's pretty much the same story. More adult clients served with these evidence-based practices than children served. But again, the trend lines are flattening out, not going down, and that's from, again, 2001 to 2012. The initiatives to support EBP implementation, basically it's things that you might expect, but then some ones that you might not. So awareness training, incorporation in contracts, but also modification of IT systems and data reports, so 88% 2009 to 12, and specific budget requests. So these are very concrete kinds of ways in which states are trying to support EBP implementation. Again, I think that's very good news. It suggests that this is being taken seriously by an increasing number of states as they're recognizing some of the things we've been talking about, having to do with how darn hard it is to get these programs implemented. The other interesting finding is that when states are asked about using research data, The basic message is they are not supporting the use of research data to understand implementation. So there's very small percentage of states that are either funding a research center institute, operating one, or even producing a directory. It doesn't mean they don't have data, and it doesn't mean that they're not using data. But in terms of understanding the implementation process itself, the states are not seeing that as something that they can do, should do, I'm not sure. That, I think, is where we need to be thinking about where is the support going to come if we're going to learn from these rollouts. And that's where the federal government, NIH, has been very helpful, of course, but where else, can we find the support to understand the implementation and get a better science based on it? Final data about this, in 2009 to 12, NASHBIT did ask about other kinds of services, and many of these are ones that we've heard about today, and we have the program developers here. So they asked about it for the first time, 2009. It's not being tracked systematically right now, only those 3 that I mentioned before. But I think it is interesting that there is a widening interest in a broader range of evidence-based practices from the state standpoint. So some implications, excuse me. Despite the budgetary crisis, states are investing in EBPs. The trend line is flat. The investment in adult services is about 2 to 6 times higher than for child services. I really have to take exception to that. Having been in this field for a while, if we want to make a difference over the long haul, we're going to have to change that. We're going to have to reverse that and start taking seriously an investment in kids' services. We can't continue to have children's services funded at such a small 20% of the rate of adult services. I think we've got to face that very directly and thoughtfully. So, but that is where we are. EBP implementation tracking is narrow. States collect data, but not systematically related to EBP implementation. So that's where all of us come in, and how can we as a field create a systematic understanding of implementation? And some of the implications, I think, are addressing the business case, the added value, addressing innovation system and organization fit, workforce issues, and performance metrics. And I'm going to talk a little bit about how we're trying to do that in our P30 Advanced Center. So we're called the Ideas Center, Center for Implementation and Dissemination in States for Children. And we have a whole team of people that are very wonderful. Let me just put it at that. So there's a whole group of us doing this work. We do use the model that Patty had talked about, coming from Greg Ahrens, Mike Hurlburt, and Sally Horowitz, and pay attention to outer context and inner context. And I've talked a little bit about some of the outer context. But in particular, where we're focusing many of our efforts now is on the innovation system fit. So how do we select innovations that are going to fit with the changing context of the system? And then innovation organization fit, meaning strategies that are going to be useful on the ground. And by on the ground, I mean at the level of agencies themselves, agency directors, middle management staff, frontline staff, et cetera. So it's the relationship between the policy environment and changes of the state and what's happening within the agencies. We have 19 studies. I'm not going to go through all of those, but a very robust number of studies, and we are responsive to, obviously, the NIMH for the funding of it, also to the State Office of Mental Health, because we're trying to make all of this work as relevant as possible to the policy environment there. And I want to talk just about one study that we're working on, because I think it has relevance for our broader conversation here about who wants to adopt what kinds of innovations, what drives whether or not an agency will sign up for something, and what do we know about the characteristics of agencies or organizations that do or do not want to participate when they are invited to take advantage of a free, quote unquote, a free training or a free system development. So we have been studying the adoption of trainings in New York State. My colleague Mary McKay and I co-direct the Clinic Technical Assistance Center, funded by New York State Office of Mental Health, with many, many different partners. And the way in which this works is that the state has said, we at the state level don't want to have to deal with all of these 346 clinics. They're serving kids and adolescents because there's too much need, too many things we have to do. So they have contracted out, basically, for this Clinic TA Center, CTAC we call it, to provide trainings to agencies and clinics in particular that are serving children and families across the state. So we have the entire cohort, the entire pool of the mental health clinics that are serving kids, 346 of them. And we're responsible for finding out what kind of training do they need, what kind of training do they want, how can we best provide that from the TA standpoint, and then we're trying to study some of these trainings and the rollouts. So one of the bigger issues that we're finding is that some of these clinics are dying. And I mean dying. They are going under. We've already lost about 20 of them. There are a number of others that are simply folding up and going home. There are others that are consolidating. The system is changing so rapidly. So one of the bigger problems is staying in business, very literally, just staying in business. So we have been working with a national council and a Rosenberg's group to identify some models for helping to make these clinics viable by helping them with their productivity, open access, centralized scheduling, concurrent documentation. So this is a very specific kind of training model. We do it through webinars. We do it through learning collaboratives. We have a group of 20 of these clinics that are teetering. They're not quite, quite off the cliff, but they're struggling. And we're working with them for a 2-year period in a learning collaborative model to help them stay in business. So that's one example. We have several evidence-informed clinical practices that we've rolled out, engagement training, and a multifamily group for disruptive behavior disorders that was developed with NIMH funding with a couple of R01s. The intensity of the training varies based on what seems to be needed, from webinar to in-person training to learning collaboratives, as I mentioned. I will mention also, even though we don't have the data on it yet, that we're just now rolling out Bruce Charpita and Eric Delayden's Managing and Adapting Practices, the MAP, and we're going to be learning a lot about that as another clinical model. Characterizing the clinic adoption, we wanted to understand, based on the attendance at any of the offerings, who was participating, who was not, and did it vary by the number of trainings, the intensity of the trainings, the type. And then we classified the clinics that participated in terms of low, medium, high, or super adopters. Super adopters are the ones that sign up for everything you offer. And by the way, these things that are offered are free in that we provide the training for free, we provide the webinars for free, we provide the learning collaboratives for free. So there isn't any cost to the agencies, but, I put that in brackets, there is a cost, of course, because staff are out of the office, there's supervision time, sometimes there's actually lost billable hour time. So it's not entirely free, even though from one sense they don't have to purchase it. The state has purchased these. I'm going to move quickly because I've only got a minute left. So one of the things we wanted to find out in terms of the context of these clinics was how difficult it was for them to take on anything new. And these are data that show the yellow lines are what they should be collecting in terms of cash flow, basically. This is what they are entitled to because they have billed for these, versus the lines of what they're actually getting. The only point I want to make here is that these clinics are in deep trouble in many cases because they are not able to capture the funds that they are billing for. And there are many reasons that we can go into it. But when we're talking about implementing an evidence-based practice, and that's what we're talking about in these clinics, this is a reality of their business model right now. So they're struggling, and yet they want to improve the quality. So it's a reality testing. I won't go through the adoption literature other than to say we don't know too much about it. It's sort of the stage one of implementation, and we know very little. There have been very few studies of that. What we have found is that there are about 22% of these clinics that no matter what we do, no matter how light the dusting, you know, it's just a webinar, lunch and learn kind of thing, they don't sign up. We are interviewing a select sample of those now with Larry Palinkas's help, and of all of these categories, in order to find out why are some of these not signing up. Is it that they're fine, don't need any help, we're doing okay? Is it that they've tried it and now they aren't interested anymore because it's not really fitting their needs? Or is it that they're really teetering on the brink? So non-adopter doesn't mean bad, it just means they're not signing up. But we do find that there's quite a variation among the rest of the groups, including the super adopters. And the interesting thing is that the low adopters and the super adopters are basically adopting at very, very different types of things. The low adopters are just doing a webinar and that's it. The super adopters are signing up for the learning collaboratives, the intensive training, the intensive ongoing consultation. So we have a fairly viable group of those super adopters, and those that are adopting are wanting to do both, the business case and the clinical supports. So they don't seem to be just selecting one versus the other. They really want both. In any of the things we're rolling out now, any of the evidence-based programs, we need to make the business case before we roll it out. And so we spend a lot of time with them on what is this going to mean for you? How's it going to affect your productivity? How's it going to affect your volume? What are going to be the ways in which you will be able to bill for this? If it's an engagement, if it's a group model, how can you bill for this? And we need to do a lot of that hand-holding, frankly, to help them think this through. But it pays off. Ooh, does a red light mean that I'm out of time? It does, okay. I always ignore those. Okay, final. I called this Sisyphus because it does feel that way at times. You know, you roll a rock up and it comes down. But there are updrafts and downdrafts. And the truth is we're doing this work and we're going to be sticking with it. And that what's happening federally is affecting the states, is affecting on the ground. The Affordable Care Act is creating fixed points of regional authority, which is good because it means you can get a better picture for where the levers of power are. And so these fixed points of regional authority are where we're concentrating many of our efforts. The EBP scaling, just looking at the end, needs to attend to the innovation system and organization fit. It's not enough just to think about installing a program and getting fidelity. That's not going to cut it in the world in which I live. We've got to be paying attention to, is this meeting the needs of these agencies on the ground? And it needs to be linked to productivity, accountability, added value, workforce, and reductions in costly services. And if we can do that, I think we have a good formula. And I think we can do that, so I'm actually very optimistic. Thank you.